Welcome to the final Experts in Conversation of the series. We are here at CTED in Madrid. My name is Charlotte Teunissen. I'm professor in neurochemistry in Amsterdam UMC in the Netherlands. And next to me is my colleague.
Hi, I'm Professor Craig Ritchie, and I'm Professor of Brain Health and Neurodegenerative Medicine at the University of St Andrews, and I'm also the CEO and founder of Scottish Brain Sciences.
So let's go to the first question and the first theme that we will discuss.
Yeah, so I think we wanted to discuss a little bit about the amyloid-targeted therapies and some of the things that we've been hearing over the last few days here in CTAD, building on, I guess, what we've known over the last year about the breakthroughs with the new monoclonal antibodies. I'm just wondering, what were the things you noticed most about what we've heard over the last 3 or 4 days?
What I found very interesting is that there were some re-evaluations of lecanemab, where they evaluated how the efficacy was when E4 carriers were excluded, because those are the people with the highest risk of having ARIA, and it didn't matter. So in the bottom line, and I think that's very good news, given the fact that some regulators don't want to include ApoE44 carriers for treatments like in the UK.
Yeah,
Yeah, so I found that interesting. Did you see it?
yeah, I did, and I think continuing on the theme of the E4 homozygotes, I think one of the things that I was really excited about was the Trailblazer 6 data, when they looked at maybe a slightly different dosing regime. And as a consequence, I think it was interesting to see how the rates of ARIA dropped to just above 10%. But the fascinating thing was that, I mean, it was small numbers, but the ApoE4 homozygous virtually had no ARIA whatsoever. So I think there's a lot of understanding or explanation for that observation, see if it plays out when they do the full analysis. But I think there's a lot of obviously excitement in the area about the benefits of these therapies, but I think to be able to address, in a sense, the Achilles heel of these drugs with ARIA was really interesting to see the steps being taken.
Yes, yes. Yeah, so I do think that's very important also to define the risk and to identify those people. And I think there was also interesting, there were some presentations about the use of AI in, defining who would develop, would be treated, or would, the treatment would be effective. But
Exactly.
yeah, I thought you can also use AI to predict who will get an ARIA or not.
Exactly, and I think there's this. I mean, we're obviously living in an age where AI is proving so much benefit in so many areas, and I think in some ways medicine's ahead of the curve. Other times it's a bit to follow, but using AI, like you say, to predict risks as well as indeed sometimes predict benefit is really quite exciting. And I also saw a paper where they were using artificial intelligence and natural language processing to have a better record of adverse events, which I thought was really interesting as well, to see how you can move away from the kind of the traditional way of measuring safety and tolerability to using AI to capture things, which probably get more of an essence of what the safety profile is.
Yeah, so I think what they did is to use AI for the coding of the adverse events, and so I think that's a helpful tool, and we have to exploit the possibilities of AI, for every aspect in a trial.
One of the other things I thought was quite interesting, now that lecanemab has been used in the US at least for around about a year, there's some real world data coming out about its use, and it seemed to me from a couple of projects, it does seem to be sort of fitting quite nicely on the label.
Yes, yeah. Yeah, and also I saw some results that also the risk of the ARIA is also quite close to what I found in the trials.
Yeah,
So I think that's encouraging.
it is. Yeah.
What I also liked was the results of continued dosing of lecanemab. Because they had a study, after finishing the study, there was an open label extension, and there was also partly a gap period. And then you saw that during that gap period, the biomarkers started to rise again. And mostly the fluid biomarkers, and A-beta 4240 was quicker in rising than amyloid PET, which means to me that it's more dynamic. Probably that reflects also how the pathology rises.
I think, it definitely, I think those data feeds into the discussion about continued dosing with a monoclonal antibody, or do you dose to clearance, then do you pause and what have you? And I think I agree. I think there's still, there will still be some debate, because obviously the two drugs available, lecanemab and donanemab, are slightly different in that regards. But certainly the data we were shown with lecanemab did certainly point towards continued dosing.
It looks like that, yeah.
And during the 3 years of that program. So I think it was quite interesting to see that in the community, the rates of ARIA and symptomatic ARIA were similar to the trials, because the trials is such a controlled environment, and there's always a slight concern about whether or not, when you're using these drugs in outside of that trial environment, things might be slightly different. So that was very encouraging as well, I thought.
I heard also of a case of someone who had the ARIA age, but outside the hospital, or they went to an emergency room, and there it was not recognized as such, and they thought it was stroke and gave anticoagulants, and unfortunately the patient died.
Yeah.
So I think that informs us that we need to have the proper infrastructure, that the patients are recognized as users of the anti-amyloid drugs, independent of which neurologist is seeing them. So it's a logistic thing.
It was actually I think it was in the Trailblazer 6 study that happened, and it was actually quite a, I remember when it was being presented by, John Sims, it was really almost a shocking moment, because you thought, even within a trial, with all the safety and all the concern and the cards that the patient would have been carrying with them and their carer, not apportioning blame, of course we're not, but that can still happen. That what was obviously a hemorrhagic event was treated as if it was an infarct, and they get anticoagulation. So I think it just speaks to the fact that we need to be so careful with informing information to the patient. But also, I think when we start using these medicines in the communities, is having educational materials for the stroke physicians, the emergency departments, etc., so that they'll know to recognize that if somebody is on a monoclonal antibody and anti-amyloid therapy, they should probably think about hemorrhagic first, rather than what's the more common infarct. So we'll talk about ARIA, amyloid-related imaging abnormalities, and in many ways, with the benefits of these drugs, it's often seen as the Achilles heel, if you like, of this class of medicines, or we believe it's a class effect in any regards. Was there anything particular over the last 4 days which you felt came to mind around this particular issue?
Perhaps the trontinemab brain shuttle results, because it's a small study, but they observed that the ARIA rates were really low. So it could be due to a lower dosing regimen that you need when you use this smart brain shuttle mechanism, because they use the transferrin transporter to shuttle in the amyloid over the blood-brain barrier. I think a smart thing, and it appears to yield better results, so quicker reduction in amyloid, and also lower rates of ARIA. So perhaps this is the way to go, to have such mechanisms.
It's really interesting how with the new therapies that they do seem, to the most part, have similar degrees, rates of amyloid clearance. And I think what's going to distinguish them, and what the next drugs or the next generation are going to try and do, is make them safer and reduce, whether it's through brain shuttle or dosing regimes or what have you. So there's obviously trials in the pipeline where they're looking at very gentle escalations of dose towards, particularly in preclinical populations, where maybe rapid amyloid clearance isn't so necessary as it would be in a symptomatic population. So I just think it's quite interesting. But notwithstanding an attempt, if you like, to make ARIA a much rarer event. One thing I was particularly interested in was the ultra fast MRI protocols.
Okay.
I think it's just, let's assume that for the foreseeable future, we are going to have to do quite detailed safety monitoring of individuals on monoclonal antibodies, and that's going to be frequent MRI scanning. If we can make those MRI scans just so much more targeted on just looking for ARIA, you don't need a hippocampal volume every time you go into a scanner. And I thought the protocols that they were describing about the ultra-fast MRI were, reducing it down to like 7 minutes, and it was as good as your full scan.
Yeah, so was it the same field strength, but just a shorter recording time?
It was as I understand it. I'm not an imager, but as far as I understand it, the acquisition sequence was just saying, well, let's just target this on looking for ARIA H and ARIA E, because all the other things you would normally get in a diagnostic scan, like brain volumes and white matter disease, etc., or more generally, if you like, weren't necessary. So let's just look for what we need to look for. If one is reducing the scan time by about a third to a quarter, you've got much better throughput in your radiology department. So I thought I just love the way the different parts of the machine are all trying to do their bit to get the drugs as safe as possible, but also be able to use them as cost effectively as possible. So I thought it was very interesting.
Yeah, it's also very interesting to see how what we learn from the evaluation of the trial data and also the real world. And there was also an interesting study who looked at how to explain the differences in area, and perhaps the question was whether the difference in affinity of the antibody towards vascular aggregates, if that could make a difference. So they compared the different drugs to vascular aggregates. But there was not a real difference that they could relate to the different frequencies of the areas reported in the trials. Yeah. So that didn't lead us to the answer yet, but I think it's very interesting to look at all the different aspects. Perhaps the biomarkers can also help us.
Yeah, exactly. Yeah. Well, I think this is something that, just generally from the conference, maybe rather than just any specific papers, was having discussions about whether or not there's predictive biomarkers for ARIA, exactly, be they imaging or non-imaging, so that we can. Now we obviously know about apolipoprotein E, genotype, but I think there's probably other things that may increase or decrease that risk relative to just the genetics and the amyloid burden at baseline, which of course are the things we know at the moment are predicting ARIA. So I think, again, as you know, in medicine, first rule, do no harm. So I think the first thing we want to try and do is make sure that we can at least communicate that information to a person, what their likelihood of developing ARIA is and whether he's symptomatic or not.
Yeah, and it's very important that studies into those risk factors are performed in the trials, and that data are shared so that many people with their different tools, as you mentioned, can access the data and target it from their point of view and from their specialty. And if I speak for myself, my interest to get access to blood samples, CSF samples, perhaps at baseline, and then relate the profiles, the biological profiles, to people who develop ARIA or not. But also, most interesting would be to have blood samples also at the time or shortly before an ARIA. I think we need to set up such studies, and I think that will only come in real world, with real world evidence, if there is more repeated blood sampling and so on.
So I think we're very good in many ways because of the chronic disorder of looking at, I guess, what we call distal biomarkers. Yeah. But looking at those proximal biomarkers for a particular event like ARIA H or ARIA E, that's I hadn't really thought about that, to be honest, but it sounds like a fascinating area to go down. And then you need to obviously have a mechanism for being able to do that in practice. But I think one of the other things that, as we're talking about safety, is the utility of artificial intelligence to help us with some of these things. And I think there were some papers again about using AI to help with safety reporting and safety monitoring, which I think is, again, using new technology. I mean, AI has been around for a long time, but we're now being able to scale it up quite significantly to again help the clinician to either do a prediction or a monitoring for these safety events.
Yeah, and also develop the AI outcomes further into translational AI, so that that we have tools that the clinicians also understand or can interpret immediately, and that it's manageable for them. I think we need to do that too.
And I know we weren't hearing about that today, but I always recall the work that you've been doing in the Netherlands with the Aboard study that is actually looking exactly at that, is that translational step, which is all good and well having the R&D activity, the research in the academic world, but how do we communicate that to the frontline clinician? And that's where, ultimately where these things need to be applied. So I think the work that you guys have been doing in the Netherlands, I think, is going to be transformative in that translational space. So.
Yeah, it's very important also, yeah. And also provide the clinicians with tools how to explain it to the patients, because it's still difficult things risk estimations are difficult to explain to laypersons, and how to deal with that and base decisions that are meaningful for your life on that.
Well, that's actually interesting you say that, and I think it's maybe going slightly off topic, but there's almost a thing of what wasn't at CTAD. And I think that kind of risk disclosure, that communication is something that we all know that we want to be able to do and do effectively. And it may have been discussed in the corridors, but I didn't see necessarily too many papers or manuscripts or evidence about those risk disclosure steps. There were appropriate use criteria they were alluded to within that. But I think it'd be interesting as we get into that real world about these types of things, which of course the patient's understanding, the clinician's knowledge, the translational steps. I think these things we'll look forward to seeing more of in the future, I hope.
Yeah, I completely agree. So that's the next step.
Yeah.
Yeah, we made already very good steps so far. So my key takeaway from CTAD this year is that a lot is ongoing. We learn a lot from the real world implementation. I really appreciate the companies sharing their post-hoc analyses also, so that we can learn more about the risk of ARIA and also extended dosing and the effects of confounders on the results. We even have not yet touched upon that, but it was also striking, and there's more to come. So what are your things?
Yeah, probably a couple of things actually. I mean, I think there was, in general terms, it was always nice to see the fact that and I know there are challenges with these medicines being used in various healthcare systems around the world, but we know we're going to get there. We know we're going to be using these medicines more in the months and the years ahead. So I think what was really encouraging was to see the number of papers, the amount of activity around making sure we're using them safely, whether it was dosing regimes or whether it was a way of assessing for ARIA in particular more quickly, more effectively, etc. The second thing was a kind of a broad, if I looked at the portfolio of research that was going on, there was a diagnostics and the biomarkers, and then there's the therapeutics. But what I really felt was the two are seamlessly joined, because that's what we do in medicine. You don't just diagnose people and you don't just treat people. You have to diagnose people to treat people. And I think that was really coming out in a lot of the manuscripts and a lot of the presentations, was how the two were becoming much more closely related in that care pathway. So I think it's just, dare say, incredibly encouraging to be where we are now, with, early diagnosis and now very meaningful interventions. And I think in the months and years ahead, we're going to learn a lot more how to use these tests and medicines with our patients in clinical practice. So that's what I'm going to take away: optimism and encouragement.
Perfect. Thank you very much.
Thank you.
And also thank you very much for watching us. And please complete the evaluation form to give us feedback and questions on the content so far and what you would like to see more in the future. Thank you very much.